Now we are entering to the important session so-called as Tech Oration. For this, we are having two eminent chairpersons. It's a great pleasure and pride to introduce both the chairpersons. Dr. Rakesh Parikh is a fellow of American College of Indo, Royal College of Physicians and Surgeons, College of Physicians and Surgeons of Mumbai, RSSDI. He is a treasurer and RSS Rajasthan State Chapter. On editorial and review boards of various journals he published, and published over 50 publications, including textbook of chapters, and also the principal investigator on several global phase 3 trials. Next chairperson. Our next chairperson is Dr. Logita Rohit. She is the director and Diabetes Care Center, Colombo, Mumbai. She is a visiting diabetologist, diabetes and obesity clinic at and she is JJ Group of Hospitals and Grand Government Medical College, Mumbai. She is a partner of Sugar Dr. Medicare LLP. And she is a treasurer and RSSDI chapter and is accredited diabetologist by RSSDI since 25 years and is the president-elect Rotary Club of Mumbai and Midtown. I'm happy to hand over the session to both the chairpersons. Thank you.
Thank you, Dr. Kannan. And it's my proud privilege to chair this session where we are honoring Dr. Moshe Philip with the first Tech Oration. This Tech conference, which is the brainchild of Dr. Bansi Sabu, is our own Diabetes Technology Conference of India. And for last 2 days, we have been discussing on various aspects of diabetes and technology in this conference. And our objective is to even involve the young minds who are involved into startups. And there is a session going on parallelly in Hall C, where around 20 startups from all over the world are presenting their work to the audience. It's my proud privilege to introduce Dr. Moshe Philip, who is the chairman of International Conference for Advanced Technologies and Treatment for Diabetes, ATTD, which was just concluded a few days back, and Dr. Banshi went for that conference. He's also the endocrinologist and director at Israel's Institute for Endocrinology and Diabetes. Professor Philip is active in both clinical and basic research. His main focus is on areas like growth, the epiphyseal growth plate, nutrition, obesity, and childhood diabetes. Professor Philip is an active member of numerous national and international organizations and has published more than 400 manuscripts. It is our most profound honor to present you with the Tech Oration for the year 2022. Thank you, sir, and I welcome you for your oration.
Thank you, the chairperson, and I would like to thank Banshi Sabu for inviting me to share with you guys the lecture I gave during the last ATTD about, and I will upload my lecture. Where is it? One second. Can you see my slide? Can you see my slide?
Yes, we can see that.
Yes, sir.
Okay. So my topic is about artificial intelligence-based decision support system. These are my disclosures. And I looked for definition of what is clinical decision support system. And I found one that I liked, which says decision support system provides clinicians, staff, patients, or other individuals with knowledge and person-specific information intelligently filtered to enhance health and healthcare. Clinical decision support system uses a variety of tools to enhance decision-making in the clinical workflow. And for those of us who work in the diabetic field for many years, and we know how difficult it is and how many decisions we have to make every day, especially if you are a person with diabetes. But the question is, do we really need a clinical decision support system? Because we have our old ways, we have used them for many years, and the question is, why do we need clinical decision support system? And indeed, when years ago, in 2006, we published a manuscript on the first time ever that people used real-time continuous glucose sensor And at that time, we didn't know what to tell our people with diabetes. It was mainly children and young adults. We didn't know exactly what to tell them, what to do with the information that they are getting from the sensor. And we had 162 participants in that study. 54 got real-time information from the sensor. 54 got a 3-day information every 2 weeks. And the last group served as a control group and used only SMBG. And after 3 months, we looked at the results, and we indeed saw that patients that use CGM continuously have reduced their hemoglobin A1C significantly. To the best of my recollection, was 1.1% less at the end of 3 months. So you can do decisions even if you don't get any specific instruction and not specific training what to do with the results of the blood glucose level in this example. No, we didn't get to the desired result. As you can see, after 3 months, we were still at 8.5, but indeed, we improved. And if you look out there, there are many guidelines available for physicians who are treating diabetic patients. For example, the ADA standards of medicine care, of medical care in diabetes that is published every year. And there are many guidelines by the ADA, by ISPAD, by other organizations, EASD, that try to help physicians to make the right decisions with the results of the different parameters that they are gathering from their patients. And I want to share with you a story that happened when I was a young physician in the emergency room. 2 buses crashed outside. There was a crash, and many wounded people poured into the emergency room. So we didn't have enough staff to deal with all those wounded people, and we asked a 6-year medical student, just finished medical school, to escort one of the wounded people to the CT scan. We told him, look, it's a dangerous place, CT scan. It might take a long time. Monitor his blood pressure and pulse all the time. And indeed, he took the patient to the CT scan and measured. And when they came back, we looked at the guy, and we immediately rushed him into resuscitation. And we asked the medical student, how come? I mean, we asked you to measure. And he said, I did. And when we looked at those measurements, he had blood pressure, the systolic one at the beginning was 122, 100, 80, 71, and less. But he did nothing with that result. And this sometimes is the situation also in our world, when there is too much data and there is no enough time for the healthcare provider to deal with all this data. And when he deals with all this data, out of those many pages of information, each physician chooses to look at something different. And we looked what happens when you give 26 scenarios of patients, of printouts of their blood glucose level results, the history, and the case report of what it's all about to 26 experts. We took 15 cases. We gave it to 26 experts from different places in the world, and we asked them to make a decision of how much or how to change the insulin titration of the pumps of people who are using CGM. So there are sensor augmented pump patients, type 1 patients, and 26 experts were asked to judge 15 cases. And you can see that they agreed on the direction of whether to increase the basal in 51%. in 41%. About the carbohydrate ratio, they agreed on 45%. How to change the correction factor, they agreed on 45%. We did the same with patients who are using pump and SMBG, 15 cases, 17 experts, and we got pretty much the same. And these results are published in the literature, as you can see from the references down there. We then went to MDI patients who are using CGM, and again, we got 62% agreement on the basal, 49% agreement on the bolus. And when we asked type 2 patients who are insulin treated on MDI therapy, we got pretty much the same. So different physicians looked at the same information of a given patient and judged it differently. So is this the reason why we are doing poorly overall? Is that one of the reasons that less than half of people with diabetes achieve a hemoglobin A1C below 7 or time in range above 70%? Is that the reason why the US, these are the recent results? I don't think so. I think there are many, many reasons, but this might contribute to it. And the question is, can we enjoy decision support system? Some electronic, artificial, intelligence-based system that can help us to make decisions. And indeed, recently, recent publications have shown the use of decision support systems in type 2 patients during routine hospitalization or routine setting in general hospital wards. And you can see that the hemoglobin A1C level, not the hemoglobin A1C, the blood glucose level went down during the days that the patient have stayed inside the hospital when they used the clinical decision support system, and more blood glucose results were within the green zone, meaning the desired zone, then in the red zone after a few days. So decision support system can help experienced team inside the hospital to treat type 2 patients. These are results of studies that have used clinical decision support system for diabetic prevention. Another study published recently that showed that a pre-diabetic clinical decision support system in a large primary care system. So there are the ability or the understanding that we can use these kind of tools is already started to be there. And when we looked at different tools, you can see that there are different tools that have shown that they can reduce the hemoglobin A1C level to show improvement in time in range and hemoglobin A1C. And I would like to focus on the one that was studied in our hospital, the DreamEd, or the EndoDigital tool that we have used and published in Nature Medicine and some other places. So what does this system, the EndoDigital, do? There is an uploader that can get the information from SMBG, from insulin, from CGMs, from pumps and connected pens, or from the diary of the person. All this information is going into the cloud, and in the cloud, the algorithm analyzes the data, integrate the data, and give the physician specific advice of how to use that information, how to change the basal, how to change the boluses, and if the patient is on pump, also the CR and CF. If the patient is on MDI, the system can provide basal bolus and the carbohydrate ratio and correction factors also. So that information, once the physician had looked at it and approved it, he pushes a button and then all the information is sent to the cellular phone of the person with diabetes to be used and change the treatment. By the way, the system is FDA cleared and is even available in the US for use. So the first step that we have done is to compare now the decisions made by the algorithm to the decisions made by the expert physician that I've showed you before. And what we have shown is that the decision made by the algorithm were pretty much in agreement with other physicians. So we thought that we have a tool that is similar to another team member. It's as if we called, it's as if we knocked on the door of our colleague in the other room and asked him, what would you do in such a case? So we took this tool to a prospective randomized study in 4 centers in the US and 2 in Europe and in Israel. The centers were the Joslin Center, the University of Colorado, the Barbara Davis Center in Colorado, the University of Florida, the Yale, and the group of Thomas Dana in Germany and Tade Bartolino in Slovenia, and my group in Israel. And it was published in Nature Medicine a year ago. And what we have shown is that when we took 108 participants and randomly selected them to use advisory guided decisions made by the algorithm, and the other group got the advice from the expert physician, and we looked at what happened at the end of 6 months. And what we have found is that there was actually no difference in the hemoglobin A1C, in the percent of time spent within the target glucose range, 70 to 180, or in hypoglycemia. So the conclusion was that if you are anywhere and you're using this algorithm, you can get to the level of those centers in your care to the patients. You're not inferior. This was a non-inferior study. For the meeting, I asked to get some information on real-world data from 10 pediatric endocrine centers in the US and in Israel that are using the system on a routine basis. They just started, most of them have information for 6 months that I looked for to get on type 1 diabetic that are using augmented pump. And we choose to look at those that were poorly controlled, meaning that they had time in range of less than 45%. And as you can see, they improved in all parameters of 70 to 180. Above 180 was lowish in the clinical use of it. And I can summarize that 50% of the population significantly increased time in range by more than 5%. Why 5%? Because 5% is what we have decided has a clinical meaning in a previous consensus that we have published. 30% of the population improved time in range, but by at least 10%. And 34% of the population reduced time above 180 by at least 10%. And what's important is that the time below 54 did not change. So when we looked at the patient information, we saw that most of them have changed the basal plan, the CF, and the CR during the 6 months of survey that we have used in the real-world data. But the system also is able to give behavioral tips. Looking at the information, the algorithm is able to analyze it and to find 130 different behavioral tips. And I would like to focus on few at this stage, only 3 of them, those that pinpoint behavior that is that identify untreated meals, meaning the patient skipped bolus for that meal. The patient bolus timing, meaning the patient gave bolus, but not in the right time to cover the meal. Or another very common mistake is overcorrection of hypoglycemia. And when we looked if the way by which we judged whether the patient have changed his behavior is by the disappearing of that comment in the next visit. And indeed, you can see that 53% changed their behavior and didn't show the same advice or the same tip or the same behavioral tips in the next visit. We had in ATTD 2020, we had a consensus on how to run a digital virtual diabetic clinic. And among the things that we have suggested that are crucial for such a clinic were a passive data transmission that from the sensor, from the pump, from connected pen, from the diary, and a decision support system that will ease the work of the healthcare provider during a visit and between the visits if they are using digital virtual diabetic clinic. And we have a long list of expectations from clinical decision support system. For example, to improve clinical performance and the care of people with diabetes, to reduce the variability in the quality of diabetic care across providers and practicing setting, and so on and so forth. But the bottom line is that we would like that the people with diabetes and healthcare providers will feel that they are not alone. When they are using such a clinical decision support system, they are not alone when they have to make a decision, whether they are healthcare provider or a person with diabetes. And eventually the vision is that those tools will be so successful that they will be used by the healthcare provider during the visit, in between the visit when they interact with the person with diabetes, but also those kind of tools will be used by people with diabetes all the time, 24 hours a day, as if they have a genie or a physician in their pocket. And whenever they have to make a decision, they will be able to consult with such a clinical decision support system, or even to get a suggestion, even if they didn't ask for them, because the genie will identify that they have been in this place before, and twice before when they visit this place, they had hypoglycemia after the visit, so maybe they should prevent it this time. And with that, I would like to thank you guys for being such an important group that are interested in how technology can help us to navigate the life of our people with diabetes. I would like to thank, I'm happy about the collaboration that we have between the ATTD and your organization. And I would like to thank my team that are working as we talk, while I'm talking. Thank you so much.
Thank you, Dr. Philip. Now I request my co-chair, Dr. Lotika, to please take over and felicitate Dr. Philip with the oration and citation.
Thank you so much, Dr. Rakesh Parekh. Thank you, Dr. Moshe Philip, for an excellent talk. It is a great privilege. You are the chair of the International Conference for Advanced Technology and Treatments for Diabetes, endocrinologist and director at Israel's Institute of Endocrinology and Diabetes at Schneider Children's Medical Center. Professor Philip is also active in both clinical and basic research, focusing on growth, the epiphyseal growth plate, nutrition, obesity, and childhood diabetes. Professor Philip is an active member of numerous national and international conferences and has published more than 400 manuscripts. It is our profound honor to present Professor Philip with the Tech Oration for the year 2022.
Thank you so much.
Okay.
Thank you, guys.
Thank you so much, sir.
Thank you, Dr. Utika. And now I think we won't have any questions in the oration. So we'll close the session and we'll request the organizers to move to the next session.